Bismillah ar-Rahman ar-Rahim. Today we will talk about the transposition of the great arteries. There are two types of TGE, the D and the L. The DTGE is an AV discordance, is an AV concordance and an VE discordance. And the LTGE, which is also named the congenitally corrected TGE, is an AV discordance and an VE discordance. AV concordance means atrioventricular concordance. So the relationship between the atria and the ventricles are normal, but the relationship between the VA, the ventricles, and the arteries are abnormal. So a normal atrioventricular relationship and an abnormal ventriculo-arterial relationship. So in this case, there is a transposition of great arteries. But in this case, there is an abnormal and an abnormal relationship. So the blood eventually reaches the right destination, from the right atrium to the pulmonary artery, and from the left atrium to the aorta through the wrong ventricles. So sometimes the LTGA or the CCTGA is called the ventricular transposition. So the ventricles are transposed. So this is the DTGA. The right atrium flows to the right ventricle, so an atrioventricular concordance, and then the right ventricle to the pulmonary artery. In the TGA, the right ventricle to the aorta. So here is a concordance and a VA discordance. So the blood flows from the lungs to the lungs, and from the body to the body. This is a CCTG in which the right atrium blood in the right atrium flows into the left ventricle, a discordance, and then from the left ventricle to the pulmonary arteries, another discordance, but negative and negative equals positive. So eventually blood flows to the right destination, but through the wrong ventricles. This condition is the DTGA is incompatible with life. So there must be a chance. We'll talk about it shortly. Okay, the arterial switch operation. This is the operation done to correct the DTGA and also to correct subpulmonic VSD. The DORV with subpulmonic VSD. DORV is the double outlet right ventricle. This is also called the Taussig-Bing pathology. In this case, we talked about it in details in the left to right shunt lesions lectures. This is a case in which the right ventricle, there's the aorta and the pulmonary arteries arise from the right ventricle, and the blood from the left side moves through a VSD that is under the pulmonary artery. So blood flows from the VSD to the pulmonary artery. So the oxygenated blood from the lungs to the left side to the VSD flows to the pulmonary artery. So this gives a pathology similar to a DTGA, and the surgery would be a switch and a baffle from the VSD to the pulmonary, or the neo aorta, from the baffle from the VSD to the neo aorta. For more details, you can go back to the left to right shunt lesions lecture. Mixing is essential for life for DTGE patients. DTGE is incompatible with life. The source of mixing must be present, either a PFO, an ASD, a PDA, MAPCA's main aortopulmonary connecting arteries, collaterals between the aorta and the lungs, and or a VSD. Mixing should be bidirectional to allow effective systemic and pulmonary flows. So this is the normal circulation in series, and this is the DTGA circulation in parallel. So the two circulations must meet through mixing, through an ASD, a VSD, or a PDE. The shunt should be bidirectional, so that some oxygenated blood goes to the body and some deoxygenated blood goes to the lungs. So the best is to be bidirectional and equal. No preferences from left to right or from right to left. And the best mixing to give these conditions is an ASD, because an ASD is a continuous mixing with bidirectional shunting. So the best is an ASD. Mixing at the level, so mixing should be bidirectional to allow effective systemic and pulmonary flows. Mixing at the level of the atria is most effective, being continuous and bidirectional. More distal mixing via the VSD or the PDE is more left to right, because of the difference it depends on the balance between systemic and pulmonary vascular distance. So the pulmonary vascular distance being lower, so the mixing is preferred from left to right, causing lung congestion and later pulmonary hypertension. So in these cases, the patient maybe is cyanosed and congested at the same time. The PDE causes left to right shunts. When severe pulmonary hypertension develops, the shunt is reversed. So this improves oxygenation post-ductal more than pre-ductal, so bypassing the brain and the coronaries, causing differential cyanosis. So in the PDE, the shunt is preferably from the aorta to the pulmonary, so the lung becomes congested. Then later, the lung develops pulmonary hypertension, so the shunt may be reversed. So the oxygenated blood flows through the PDE to the aorta, bypassing the great vessels to the lower body. So the lower body becomes oxygenated, and the upper body is deoxygenated, causing a north-south syndrome or Harlequin syndrome. The presence of a VSD improves the saturation and trains the left ventricle, but prolongs and complicates the operation. So the presence of a VSD, when there is an ASD and a VSD, so the mixing is better. Maybe the lung is congested a little, but the oxygenation becomes better. And also the left ventricle is exposed to the aortic pressure, so it remains conditioned for a longer time. We'll talk about this issue shortly. Pulmonary hypertension may develop easily due to pulmonary overflow, hypoxia, acidosis, pulmonary venous congestion. So all these causes may increase pulmonary vascular resistance. Pulmonary overflow from the left to right shunt through a VSD or a PDE, hypoxia, acidosis, and pulmonary venous congestion. Prognosis worsens with increasing age and may need hemodynamic study to measure pulmonary vascular resistance. This shows the difference between the total blood flow in the aorta and the pulmonary and the effective blood flow. So all this blood is not effective. It's only effective in giving an intravascular volume, a cardiac output, but it is not effective as a transport medium. So the blood, this red and blue blood is not effective as a transport medium. It is not effective to transport oxygen, carbon dioxide, nutrients, and waste products. So the effective part of the blood flow is what concerns us and is what we tend to increase. So shunting may be through an ASD, VSD, or a PDE. During systole, blood flows from the blood flows through the PDE from the left to right shunt, and if there is a VSD here, it will also be from left to right. And then the pulmonary flow increases, causing higher blood flow to the left atrium that forces blood to pass from left to right during systole, and then during diastole the reverse occurs. So the shunt in the ASD is bidirectional. This image is during systole. It shows a unidirectional flow during systole, but during diastole blood flows the other way around. So there is better mixing at the level of the atrium. Also at the level of the PD there is a bidirectional. During diastole blood flows from the aorta to the pulmonary, but to a lesser extent. During diastole blood flows from the pulmonary to the aorta, but this shunting is more preferably left to right. So as you can see here, the blood flow in the pulmonary is more than the aorta, so the lung becomes congested. So the best shunting is a large ASD, and this is the aim before the operation. The aim is to increase the size of the ASD. The QPQS, the total pulmonary flow, to the total systemic flow, is composed of the recirculating blood flow plus the effective blood flow, and the effective blood flow plus the recirculating. In a TGA with a VSD, high QPQS, less effective systemic flow. In a DTGA with a wide ASD, balanced QPQS. In a DTGA with an LVOT obstruction, or otherwise you can call it a subpulmonic stenosis, low QPQS, less effective pulmonary flow. So the patient becomes cyanosed. LV conditioning. If the LV is deconditioned, the switch is not possible, and then mustard atrial switch operation is needed. LV conditioning occurs after roughly 2 months of age. So to go back to the image, in cases of DTGA, after birth, the left ventricle is exposed to the pulmonary artery pressure, the pulmonary vascular resistance, and the right ventricle is exposed to the systemic vascular resistance. So the right ventricle hypertrophies, and the left ventricle thins out, the wall thins out. It is called deconditioning. And the longer we wait, the more the deconditioning, up to the point that the left ventricle becomes unable, the mass of the myocardium of the left ventricle becomes unable to handle the aortic pressure. So if we do the arterial switch operation later than 6 weeks or 2 months, the ventricle may fail after bypass. It may not be able to tolerate the aortic pressure, so it fails. Not because the ejection fraction is low, but because the muscle mass is low, is thinned out. It is a negative hypertrophy occurs. Negative hypertrophy occurs to the left ventricle. This is a form of adaptation. The right ventricle hypertrophies and the left ventricle thins out. So this is what happens. So we should. That's why this surgery is done neonatally, and the younger the patient, the better. Sometimes it is done in less than 24 hours. We once operated on a patient 16 hours old. It was planned prenatally. The patient was diagnosed prenatally, and the mother, she went to the university hospital to give birth to the patient. And the neonate, he was transferred quickly to our hospital and was operated immediately. So we said that a VSD trains, we said here, the VSD trains the left ventricle. So if there is a VSD, the left ventricle becomes exposed. The left ventricle here, through a VSD, becomes exposed to the aortic pressure. So the deconditioning is delayed. So So deconditioning occurs after roughly 2 months of age. But if there is no VSD, it may be less than 2 months. LVOT obstruction. The presence of an LVOT can keep the left ventricle conditioned for a much longer time, even to school age, and this switch is still possible because the left ventricle is exposed to a high afterload due to the stenosis. So the patient remains switchable for a long time. If the LVOT is unrepairable, then Rastelli operation or a root replacement operation is needed. So in these cases, if the patient is lucky and the type of LVOT obstruction is easy to treat, like a simple membrane or a muscle ridge that can be removed easily, or just some fusion of the cusps that can be opened or dilated with the Hager dilator. So this patient is lucky because he can reach an older age, and the operation is still possible. So this is a lucky patient. But if the type of LVOT obstruction is unrepairable, like an extensive hypertrophy or a small annulus or things like that, then a different type of operation is indicated. Rastelli operation or a root replacement operation. We'll talk about it in the next part of the lecture. LVOT obstruction may be dynamic due to the high RV right ventricular pressure and deviation of the interventricular septum towards the left ventricle may get relieved after the arterial switch operation without intervention. So if the RV high RV pressure becomes released, and if the pressure falls and the left ventricular pressure rises, so the septum may go away from the LVOT, and the right ventricle becomes less hypertrophied. So this dynamic LVOT obstruction may improve. This is what we will do in a LVOT obstruction. If there is a TGA with an LVOT obstruction, if it is dynamic or resectable, we resect it and do an arterial switch operation. If it is fixed or unresectable, then if the interventricular septum is intact, we do Senning is a master operation, plus or minus LV to PA conduit, or we do a switch and a conduit. We'll talk about this later. If there is a VSD, if the VSD is distant, we do an Nikaido, which is a root switch, or if it is committed to the aorta, we do a Rastelli or REV operation. We'll talk about all these in details later. The coronary anatomy may present a challenge for the surgeon to transfer them to the new aorta, and may need a preoperative CT scan, because we do not only switch the arteries, we take the coronaries with the aorta to the new position, the new aorta. If severe cyanosis, the neonate may be on prostaglandin E1 to keep the PDA open, mechanically ventilated, on fluid resuscitation, may need urgent balloon atrial septostomy, Rushkind, then semi-elective arterial switch is needed. And this is common. The dehydration is common because usually these patients are born elsewhere, and then after a while they are diagnosed with a TGA, and then they search for a specialized center to do the surgery, and then the patient is transferred, maybe across cities or across the governorates to reach the hospital. So sometimes these patients are dehydrated, and with the dehydration the cyanosis increases and the patient becomes may present with heart failure. So usually when these patients arrive, they need resuscitation, maybe mechanical ventilation, prostaglandin E2 infusion, and may need balloon atrial septostomy, the Rushkind operation, to widen the PDA to become a proper ASD for better mixing. This is the Rushkind operation. It is done under imaging or bedside with an echo. They insert a catheter through the femoral or the umbilical vein, and then passing through the PFO. They inflate the balloon and then forcibly they pull the catheter to tear open the interatrial septum. PDA dependent cases are highly critical. The arterial saturation is dependent on the prostaglandin E2 infusion, low FiO2 as low as possible, better on room air, high systemic blood pressure to keep it, and may need vasopressors, and good filling. This low FiO2 setting may be counterintuitive for us as an anesthetist or intensivist. So how come a severely cynosed patient does not get oxygen? It's a very rare condition that we find a patient that is with a saturation of maybe 30 or 25 or 40, and we do not open oxygen. We open room air, or we do not give oxygen at all. We leave him on room air, which is counterintuitive, but it is important to consider this condition, so that opening oxygen may close the PDA and decrease the cyanosis, increase the cyanosis, decrease the saturation more. Because this patient is in no lack of oxygen or ventilation. If the lungs are fine, so he is in no lack of oxygenation and ventilation. His problem is in the shunting. So we have to improve the shunting with the prostaglandin E2, with an increased blood flow, the good filling, and avoid closure of the shunt by the high oxygen. After birth, the patient is exposed to the atmospheric oxygen, which is higher than the oxygen tension in the blood of the mother. So the PDA closes. So we have to avoid this high oxygen content to reach the PDA. Side effects of prostaglandin E2 are fever, apneas, vasodilatation, hypotension, decreased intravascular volume, tissue edema, hypertonicity, and CNS excitability. In DTGA with an intact ventricular septum, the saturation is usually less than 60%, and intervention may be urgent before closure of the PFO and the PDA. We said previously that that the presence of a VSD trains the left ventricle, but prolongs and complicates the operation, because the patient will need to close. We will need to close the VSD of with the patch. So this prolongs the operation, increase the bypass time and the cross-clamp time. So the patient may come out after surgery with more complications from the bypass. But due to the training of the left ventricle, the left ventricle may tolerate the aortic pressure better. Rushkind is done in the cath lab or as a bedside emergency guided by echo via the umbilical vein. Failure of Rushkind to improve oxygenation may indicate pulmonary hypertension. Effects of cyanosis, polythysemia, increased viscosity, thrombophilia, increased pulmonary vascular resistance and systemic vascular resistance, increased blood volume, and vasodilatation. Surgically, arterial switch operation if the LV is conditioned. If the LV is not is deconditioned, so we do another surgery, the mustard operation, in which we switch the atria and not the arteries. So the mustard operation is an atrial switch operation rather than an arterial switch operation. We'll talk about it later. Okay, if the patient with mustard operation can be operated later, 2 to 3 weeks. If this delay, this decondition occurs within 2 to 3 weeks in intact ventricular septum, and 6 to 8 weeks, as we said, 2 months in a VSD case because the left ventricle is exposed to the systemic pressure. If the left ventricle is borderline between conditioned and deconditioned, and we can't decide whether to do a switch or a mustard, training of the left ventricle can be done by a pulmonary artery band generating pressure that is half to 2/3 the systemic, plus an MBT shunt if severe cyanosis. So this band would increase the afterload and may train the left ventricle to become hypertrophied enough to become clearly conditioned to do an arterial switch operation. This is called the first stage and the second stage. The first stage switch is the pulmonary artery band and a shunt, and the second stage switch is an arterial switch operation. The presence of hypoplastic aortic arch indicates concomitant repair, but this prolongs and complicates the surgery. Patient would need hypothermic circulatory arrest to repair the arch. MBT shunt in the neonate is too small or unrepairable. If the neonate is too small or unrepairable, we go through the single ventricle algorithm, that is an MBT shunt. This is the arterial switch operation. We cut higher than the level of the aortic and the pulmonary roots. We cut at the level of the ascending aorta and the main pulmonary artery, and then we switch the arteries. We take the aorta from here and put it. This is the distal aorta. We suture it to the pulmonary valve, and then we suture the pulmonary artery to the aortic trunk, and then we cut off the coronaries and we insert them to the new aorta. And in place of them, we put pericardial patches. So now the pulmonary became the new aorta attached to the coronaries and continues as the aorta. And this is the new pulmonary artery. So this is the arterial switch operation. We start with cutting off the arteries, and we take the coronaries. Then we suture the coronaries to the new aorta, and then we suture the distal aorta, and then we clamp off. And the suturing of the pulmonary is done off clamp, under bypass of clamp. Anesthetic considerations. These are the anesthetic considerations of neonates in general: hypoglycemia, variable pharmacodynamics and pharmacokinetics, lower MAC of volatile anesthetics, respiratory, large head and narrow epiglottis, sniffing position, low function residual capacity, easily becomes hypoxic, and the patient is usually already cyanosed. So if the intubation is difficult due to these conditions, pre-arrest or severe hypoxia and pre-arrest, and the patient may become bradycardic, is often encountered. Cardiac output depends on the heart rate, diastolic dysfunction, higher parasympathetic tone, immature cerebral autoregulation. Hematologically, the hemoglobin level is high, the blood volume is higher than adult, vitamin K clotting factors are deficient. The myocardium depends on extracellular calcium for inotropy, because the sarcolemma, the sarcoplasmic reticulum is underdeveloped. So the myocardium depends on extracellular calcium rather than the calcium in the sarcolemma for contractility. In adults, we depend on the sarcolemma for contractility. The calcium flows to the cytoplasm during electrical excitation. Calcium influx from the sarcolemma to the cytoplasm, causing contractility. But in neonates, they depend more on extracellular calcium. So if you give the patient calcium, the blood pressure rises significantly and the contractility improves significantly. Thermoregulation. Easy hypothermic due to the low subcutaneous fat and immature brown fat, and due to the large surface area to volume. It affects metabolism, shifting oxygen dissociation curve to the left, causing coagulopathy and increases pulmonary vascular resistance. In a patient that may be already pulmonary hypertensive and may be already coagulopathic. Hemodynamic goals: maintain duct patency, maintain cardiac output, maintain pulmonary vascular resistance less than systemic vascular resistance, unless there is a large VSD and a congestive heart failure. Maintain good hydration for lung and body perfusion and to decrease viscosity. Induction: the presence of an IV peripheral cannula is highly recommended for good hydration, to avoid inotropes, to give inotropes or vasopressors if needed, and to induce anesthesia IV, because in these cases induction of anesthesia with inhalation sevoflurane may render the patient unstable. So the presence of an IV peripheral cannula that is inserted while the patient is awake provides better induction and gives us access to IV access for emergencies. ECG, pulse oximeter, non-invasive. We give midazolam, ketamine, and atropine as an antisynagogue. Sevoflurane, 5% if no IV cannula. Induction is slower in cyanotics. Fentanyl, 1 to 2 micrograms per kg, muscle relaxant. Intubation may be oral. Intubation by oral non-cuffed endotracheal tube. Leak test is done. It is expected that the leak may increase after cardiopulmonary bypass and the MUF due to resolving of airway edema by the filtration. So a significant leak, even if tolerable before bypass, may become intolerable after bypass, and patient may become may be non-ventilated after bypass if the leak is significant. So a minor leak before bypass is acceptable, but a large leak that is compensated by a pressure control ventilation or something or an oral pack is not acceptable, because after bypass you may find the patient non-ventilated. Usually the patients weigh less than 5 kilograms, so usually the TE is not used. The temperature probe is inserted orally to reach the hypophalanx. An arterial line is inserted in the femoral, radial, or axillary arteries, preferably the femoral. A central venous line is inserted in the internal jugular vein or femoral vein, preferably the internal jugular, because the femoral vein is usually small and the leg may become compromised and congested. Ultrasound guided. Check the vitality of the limbs after cannulation and avoid cannulation of the femoral artery and vein on the same side. Although the femoral artery may cause complications to the leg, but it is more reliable than the radial artery. The radial artery in neonates is difficult and may not be reliable, especially that the operation is prolonged. So the radial, although being safer, but it is less reliable than the femoral. Maintenance: maintain the same anesthetic goals. Further doses of fentanyl as needed. Morphine infusion till transfer to ICU. Muscle laxant infusion. SIVO less than MAC. There is no evidence that steroids have beneficial role to reduce inflammatory response, and there is evidence that they increase length of stay and insulin need, but still we may give them. There's not enough evidence to give or not to give steroids, but we usually give steroids in neonates due to the long bypass time. Mechanism of central nervous system injury are multifocal. Preoperative brain malformations, perioperative hypoxia, ischemia, emboli, low cardiac output states, the bypass and the deep hypothermic arrest. All these these may cause CNS injuries. The use of cerebral oximetry to measure the regional saturation is recommended. Heparin doses. We give heparin, maintain ACT more than 400 or 3 times baseline. The ACT is inaccurate and many factors can increase it despite low heparin, like hypothermia, hemodilution, platelet dysfunction, preoperative coagulopathy. 2-liter heparin may cause microthrombi and consumption coagulopathy postoperatively, and too much may cause bleeding, so it should be judged. Management of low ACT, heparin resistance. Give further doses of heparin. Maybe the heparin is defective, the cold chain is interrupted, or so we give further doses of heparin from a different patch, not from the same patch. Better from a new batch of heparin ampoules. Order for fresh frozen plasma, because if this really is a case of heparin resistance, so usually there is a deficiency in antithrombin 3, which is the factor that heparin works upon as a cofactor. So in the absence of antithrombin 3, the heparin is not functioning. So we provide the patient with an antithrombin 3 in a fresh frozen plasma, so the heparin would find the substrate on which it would attach, activating the antithrombin 3 and allowing it to work as an anticoagulant. Tranexamic acid at 10 to 15 milligrams per kg plus 5 milligrams per kg per hour infusion. Separation from bypass after no significant surgical bleeding. Adequate reperfusion time, which is usually at least 1/3 the ischemic time. Rewarming, de-airing, good biventricular function, and no ischemia in ECG, because for 2 reasons. We transported the coronaries from one place to another. Maybe the sutures are stenotic, narrowing the orifices. Maybe there is a kink or a stretch on the coronaries. Maybe the distance that the distance between the original position of the coronaries and the later position is too far, so we needed to pull or dissect the coronaries to reach or put a graft in between. All these may cause ischemia, so we have to make sure that the coronaries are not ischemic. Sometimes the surgeon, after putting the coronaries in the final position, he requests for some cardioplegia to be pushed in the coronaries to make sure that they are patent. The second reason for ischemia is the LVD conditioning. Maybe the left ventricle exposed to the high aortic pressure. It may become ischemic due to the strain, and maybe other causes like air emboli or poor preservation on bypass and cardioplegia. So we should check the ECG. No arrhythmias. The heart rate at least 140. We may give atropine and we may pace the patient, preferably atrial pacing. Inotropes, Marinone and NORAD, and maybe adrenaline if needed. The LA line is very important. Pacemaker wires, dual, in case of blocks, especially if the patient has a VSD that is closed by a patch. The conducting system may become compromised. At separation, we administer calcium. As we said before, it is a good positive inotrope. Maintain systolic pressure. Fresh blood and blood products are given carefully using a syringe and not by dripping, because these patients are very sensitive to volume, because of the ventricle is surprised by the presence of the aorta as an afterload. So this surprise may fail the ventricle. So we have to be very careful with this ventricle, even if the ventricle is conditioned before the operation. Yet a degree of deconditioning has started, so the ventricle should be treated as a failing ventricle. So we should give volume carefully, and the problem is that due to the suture lines and the long bypass time, usually, and the coagulopathy, usually the bleeding is profuse, and we give much blood. So, and we may spend an hour, 2 hours, or 3 hours giving the patient bleeding, and we are giving blood. Patient bleeding, and we are giving blood, and we are moving in a very narrow window between hypovolemia and LV failure. So we are treading a very treacherous path between these two extremes. So this narrow window, we should give blood carefully for the systolic pressure to reach the optimum pressure for the patient, which is debatable. Sometimes less than 55 is good or is enough for the patient. We should check the signs of perfusion, like the urine output, the lactate level, the acidosis, and give blood accordingly. So if there are good signs for perfusion and the blood pressure is fine, so we replace the blood lost with blood carefully, because if we overdose the patient, he may easily fail. If the aortic pressure falls and the LA pressure falls, we put a LA line, as we said before, which is very important to be able to monitor the left ventricle before and after, the preload and the afterload. The aorta, represented as the femoral artery pressure, is the afterload, and the left atrial pressure is the preload, measured directly with a line passing above the drapes, and we connect it to another transducer. So we have two transducers, one for the femoral artery and one for the LA line, and we monitor them carefully and vigilantly. When both fall, which what happens throughout the hemostasis period, we give blood till they go back to normal. If both are high, so maybe we need anesthesia and not give volume. If the aortic pressure is high and the LA pressure is low, so the patient may need volume or anesthesia. What we dread is this condition in which the LA line rises and the blood pressure falls, or if both of them are low, and then we give blood, so the LA rises and the blood pressure remains low. This is a failure condition. In this case, we maintain the LA pressure between 5 and 8, watch for rapid rise in LA pressure without increasing the arterial pressure, indicating LV failure. In this case, we give calcium, and we monitor calcium level in ABG. And sometimes the failure is due to hypocalcemia, because we are giving blood in profuse amounts, and this blood contains citrate, so the patient becomes intoxicated with citrate. So we give calcium. So throughout the period of the hemostasis, calcium falls and we replace it, and falls and replacement. And with this fall, blood pressure and LV function falls. So we give calcium to replace the calcium and improve the inotropic state, the LV, the condition of the contractility. Also, we should not run away with our with giving calcium, so that the patient becomes hypercalcemic. So we should give calcium till it becomes till it is normal. Sometimes we take an EBG sample and we find the ionized calcium level more than 2, which is too much. So we should monitor the calcium level, stop blood transfusion, raise the head, allow the baby to bleed to target condition. And actually this is what usually happens. If we give too much blood and the blood the blood pressure doesn't fall greatly, we leave the patient to bleed the excess blood that we have given him, because usually these patients are in continuous bleeding. So this high this extra blood would be bled out shortly. Withdraw blood if needed. If the patient is falling rapidly, we can withdraw blood that we have given. The blood that we have given, we can withdraw it and throw it away. Adrenaline if all fails. Membrane ultrafiltration is usually done to increase the hematocrit, to concentrate the clotting factors and platelets, to increase the blood pressure, increase pulmonary vascular resistance, remove inflammatory mediators. It has been shown to decrease bleeding significantly. Actually, membrane ultrafiltration has strong evidence to remove inflammatory mediators, as in contrast to the steroids, which are debatable. So membrane ultrafiltration is very important. It is advised to do peripheral echo before chest closure, TE if possible. Follow up post bypass urine output and serum lactate. For hemostasis, give fresh blood, platelets, maintain normothermia, continue antifibrinolytics, recombinant factor 7. Chest closure is usually not possible due to myocardial edema and coagulopathy, and the patients are often transferred stented. However, some patients are closed if the LV condition is fine, the blood pressure is good, there's no vasoplegia, and the hemostasis condition is fine. And in some cases, we ultra fast track the patients and we extubate on table, but this is rare, but sometimes we've done. This is a diagram to see how much wires and tubes are coming out of the patient, the pacing wires, the drains, the peritoneal catheter for the peritoneal dialysis, the LA line, and here they are putting a PA line, which we do not do, but maybe some surgeons leave a PA line, pulmonary arterial line. Long-term complications, pulmonary atresia and RVOT stenosis, new aortic valve insufficiency, coronary artery obstructions. Thank you.